We now move on to our next session, a keynote address. It's our honor to welcome Dr. Satish Adiga once again, this time for a keynote on the topic Innovations and Insights in the Embryology Lab. Let's warmly welcome Dr. Satish Adiga to deliver the keynote address. Over to you, Doctor.
Good evening once again. So I'll be talking on innovations and insights in the embryology lab. The special focus on the gamete analysis to embryo selection. This is the outline of my presentation. Next 20 minutes I'll take you through the biology of reproductive cells, and then before I discuss about the assessment, and then I'm going to end with what's going to be the future embryology lab. In embryology, we deal with very unique cell types, the sperm, oocytes, and embryos, which are very unique with respect to their shape, size, the chromatin architecture, the epigenetics, metabolism, and their antioxidant defense. Specifically, if you look at sperm, we know that spermatogenesis is a continuous process and millions of sperm are produced every day. And we embryologists, we tend to ignore sperm. We are more concerned about the oocytes. The oocytes are very precious for us because sperm are available in million. And even we see patients who are above 50 years, they produce completely normal ejaculate. So what is the impact of age on the ejaculate or the sperm quality? So it has been shown that men aging is negatively associated with the chance of live birth, and the mean probability of live birth decreases with the men's age. There are various reasons for this. As we know that with the age, there is accumulation of more and more de novo methylations, de novo mutation. There is a risk of imprinting errors, the methylation errors, DNA methylation error, histone modification, and eventually there is also a substantial risk of transferring this defect to children. So if you look at sperm structure is very unique. As you see here, the sperm has got a very unique chromatin. We call it a protamase. And the small structures are the histones. The protamines are very important because they help in condensation of the chromatin and also for fertilization. And the histones should be completely replaced by protamines in sperm. So what actually happens if the histone is not completely replaced by protamines, then there is a risk of epigenetic errors. In fact, this is our own study where we have shown that the retention of histone in the sperm, in normospermic ejaculate, we call it maybe comes under idiopathic infertility, which can negatively influence the functional competence and the embryo quality. Another important topics which is being discussed these days is sperm DNA fragmentation. We know that there are the several causes for sperm DNA fragmentation. It's multifactorial. And about 10 years ago, we have shown that the poor quality ejaculate and advanced age are associated with increased sperm DNA damage in infertile men. And now it is very clear that there is a strong association between the sperm DNA fragmentation and increased risk of miscarriage in the partners. Unfortunately, the conventional semen analysis does not address the nuclear integrity, the genetic or epigenetic integrity. Though the semen profile is above the 5th percentile, there is always a disclaimer attached to the conventional semen analysis, which means anything above the reference range cannot guarantee fertility and vice versa. So why do we need to really worry about sperm? You know that if you look at sperm contribution to live birth is only 15%, unlike oocyte. The oocyte contributes significantly. It's a driving force for fertilization and early embryogenesis, whereas sperm contributes only 10 to 15%. But importantly, if you look at the negative influence made by the abnormal sperm, which is 3 times higher than normal spermatozoa. Hence, it is very important to understand the pathophysiology associated with the sperm and its possible impact. So if you look at sperm selection, our sperm selection which is done in the lab should consider not only the fertilization or getting good quality embryos or chemical pregnancy. What is important is that our selection should aim at getting good healthy offspring. And unfortunately, the parameters what we use these days, they can mislead. There are certain easy ways or physiological ways where we can improve sperm competence, the sperm function. One is with the short ejaculatory abstinence. We know that the epididymal transit is very important. Sperm should stay in epididymis for a few days, but prolonged stay can compromise its functionality. So if you look at the literature, there are several studies which show that the short abstinence of less than 2 days is superior in getting fertilization. The fertilization rate is higher if you allow only 2 days of abstinence compared to more than 4 days of ejaculatory abstinence. In fact, this is our own study where we looked at the association between the ejaculatory abstinence and the quality of the sperm in close to 8,000 subjects. And here is the summary which shows that in normospermic ejaculate, if you allow only 0 to 2 days of ejaculatory abstinence, one can get good quality, the good motility, the good viable sperm, the good morphologically normal sperm. So, if you have a patient with unexplained idiopathic or unexplained infertility or idiopathic infertility, probably it's always good to go with a short ejaculatory abstinence so that we can extract competent spermatozoa. We all know that motility is also very important to attain fertilization. The sperm should attain hyperactive motility. Unfortunately, what happens in a routine semen analysis, the sperm hyperactive motility is not being tested. We look at only the progressive motility and non-progressive motility, and these days it has been realized that this Caspar channel, the Caspar channels are very important. As you see here, they are in the sperm tile and they help in the migration of the calcium from outside, which makes the sperm to undergo hyperactive motility. So if the sperm cannot attain hyperactive motility, then probably it may not be able to fertilize the oocyte, and it has been suggested that the patient with the Caspar defect, they are infertile, and then the only option is available is to take them for ICSI. So now there are techniques are available. This is a new technology from Trion, which is a startup of the University of Munster. They come out with the easy kit which has got only test and control, so it's very easy to do. You can mix with the ejaculate and look under microscope, look at the motility, and then you can easily calculate the Caspar index. So it's a very easy technique, and the Caspar index, they say that if the Caspar index is above 80, then it's unlikely the patient has Caspar defect. And if the Caspar index is less than 80, that means there is a possibility that the patient has Caspar defect, and ideally it's important to take the couple through the ICSI, because there is no point in doing IUI for this patient. So as I said, the Caspar analysis or the Caspar defect analysis, it cannot increase the pregnancy rate, but it can reduce the time to pregnancy, because right away you can take your patient to ICSI instead of taking them through several cycles of IUI. And these days we are also more interested in about non-invasive selection of sperm, because we know that once we identify the sperm genetically or epigenetically normal sperm, we should be able to use it for fertilization. So the non-invasive technologies are being developed these days. And this is one of the techniques which I came published only a few weeks ago, in the last month itself, which uses the autofluorescence technology, autofluorescence of the endogenous metabolites, and where they look at the FAD, NADH and NADPH, and they can easily segregate them to two cohorts from infertile and fertile. So probably this is going to be adapted for the metabolism based sperm selection for the future assisted reproductive technology. And as you all know that the spermatozoa are well protected in the ejaculate. So as soon as you take them out, the sperm tend to experience stress. So it could be the sperm wash technique or centrifugation, pipetting or cryopreservation, which can substantially increase the damage to spermatozoa. And in fact, this is our own study we published 15 years ago. We showed that the poor quality sperm are more susceptible to experience morphologically abnormal sperm, are more prone to experience damage during cryopreservation, and there is a higher risk of the introduction of the DNA fragmentation with the freeze-thaw process. This is one example. So what is important here is that it is always good to go with the technology which can cause minimum stress or damage to the spermatozoa. These days people are going towards the microfluidics technology. Microfluidics works with the natural selection process, what actually happens in the female reproductive tract. It works with the principle of chemotaxis, thermotaxis, and rheotaxis. So there is no centrifugation, no pipetting, one can extract competent sperm. So there are several devices are available these days, and this is one of the one which I came across very recently, which has got a multi-channel microfluidics. As you see here, there are multiple channels. So this device has shown to reduce the DNA fragmentation significantly in comparison to density gradient technology. And since the numbers are very high, you can even use this wash sperm for insemination, because that is one of the limitations of microfluidics technology, because the sperm yield is not adequate for insemination, but they say that one can get in millions. This is our own one of the product which we developed 2 years ago, which is known as the MIGLIS, or the migration sedimentation. So this is an easy technique again. So this has got 3 different few compartments, and where we keep the ejaculate, overlay with the medium, and just incubate it for about 1 hour, and then you can, after 1 hour, you can collect sperm from here and then use it for insemination. This device is also very helpful in eliminating the DNA fragmented sperm, and also in getting good number of viable spermatozoa. And but unfortunately this product is still with our the collaborator in Japan, and they are yet to produce it for the clinical use. So there is also a possibility to integrate AI technology in sperm selection. There are several devices, technologies are available looking at the morphology. So it's an easy job for embryologist. You have to tell how many sperm you require, and then it classifies based on the magnification, and then you have the technology to select, and then straight away you can use it for ICSI. So when we come to oocytes, apart from conventional morphology based analysis, now there are techniques available to use cumular cells. As I told you earlier, the cumular cells are the nourishing cells, and the health of the cumular cells reflect the health of the oocyte. So there is a technology now available to assess the cumular cells, and which can help in increasing the chance of conception. This technology is known as the Aurora test, which is by the Adiga. And here what they say is that whenever we get the oocytes, we denude them, send the cumular cells to the company in the individual PCR tube, and then you proceed with ICSI. On day 3, when you have embryos, you will also receive the score, the Aurora score from the company, which will help in selecting the good quality embryo. So if you look at the results are quite interesting, and the clinical pregnancy as well as live birth rates are almost double when this technology is used for selecting the embryo. Similarly, there are many other non-invasive approaches. This is not this again a metabolomic fingerprinting uses non-invasive magnetic resonance spectroscopy. They say that it is pretty safe for the oocytes. And the another technology is known as METAFER. Again, it's a metabolic evaluation through the phaser-based hyperspectral imaging technology. But this technology it is not available in the market. Now, use of this AI in oocyte assessment. This again by the Future Fertility. This product is available in the market, where this is a morphology based selection, and this score is a magenta score. The magenta score is less than 2.5, then there is only 18% possibility that the oocyte will progress to blastocyst. On the other hand, if the magenta score is more than 7.5, there is about 50% chance that the oocyte will progress to blastocyst stage. So this is another technology by fertility, and this is known as CLOE-OQ. OQ means the oocyte quality assessment by the AI technology. Again, this is again a morphology based. You have to select the assessment is through the morphology, uses the algorithm, and then gives the score. You can see here the OQ score is 1.2. The oocytes are morphologically comparable in all 4 images here. No embryologist can make out any difference. But if you look at the blastocyst here, they arrested, whereas the score with 9 and above 9, they could give us a good blastocyst. So this can help in predicting the quality of predicting the blastocyst development. So we are again in the era of automation. This is ICSI automated, and it's a new technology again. It is not come to India. And what it does is that it does everything. The embryologist have to just control the device, and then it selects the sperm. As you see here, this is a very different kind of needle. There is no spike, no bevel here, and very precise. It works through a pulse like we do it in piezo ICSI, and sperm are well controlled, and the minimum trauma. Everything is computer controlled here. You can see how precisely it is being injected, and without any aspiration of the ooplasm, the sperm are very nicely deposited. So that means it is a great technology. Yeah. So with all these things, we know that success is not 100% in ICSI. Even with ICSI, we see about 1 to 3% of our couples experience fertilization failure. But we also know that it's a number related. For example, if you inject only one metaphase to oocyte, there is a 37% risk that we may end up with fertilization failure. Again, it's all number dependent. You increase the number, risk reduces. So we know that there are various reasons for fertilization failure post ICSI. And one reason could be is a defective activation. The sperm has to activate the oocyte, and now it has been shown that the aggressive immobilization can increase the chance of fertilization if there is a previous low fertilization. Here the group where the fertilization is only about 20%, but if instead of conventional immobilization, if we do in the aggressive immobilization, the 15 times more, then probably your fertilization rate increases by 50%. So this can be easily attempted by the embryologist, and it's not going to cost any extra for us in the lab. The another approach is use of assisted oocyte activation. You know that assisted oocyte activation is basically for the PLC zeta defect. If the sperm has any defect, this will help in increase the fertilization. But now this is one of the safest techniques, and by exposing calcium ionophore to oocyte, it is not going to make any harm. And this study by the Palermo's group has shown that this assisted oocyte activation is helpful significantly with the history of previous poor fertilization, poor implantation, and where all this can be increased significantly and with a significant reduction in the pregnancy loss. So in IVF lab, we know that there are certain modifiable and non-modifiable factors. There are like the patient age, andrology, genetics, lifestyle, pathology. They are not under our control. They cannot be modified. Whereas there are certain modifiable factors. It could be the environment in the lab, the machines, people, or protocol, GLP. These are the modifiable factors, but they can be easily controlled. And in fact, now it has been clearly shown that the IVF lab is the most important factor which controls the embryo phenotype. It could be the machines, people, environment, or whatever it is. Hence, it should be taken into consideration. And we know that the embryo culture system is very important, where embryologists should give more attention to embryo culture system. And there are different types of culture media are available. I'm not going to discuss more about that. But unfortunately, today's culture media, we use either single step or sequential depending upon the requirement. But most of the time, we do not know the composition of the medium. And people also include the antioxidants, cytokines, and growth factors supplemented, but we have absolutely no idea what all things culture media have. There is no evidence on the superiority of the one media over the other media. So we expect that in the future culture media the composition should be transparent. We should know what exactly it should have, and it should be optimized for the dynamic culture. That is the future of embryo culture. There should be a dynamic culture. There should be more evidence coming on the supplementation, additional supplementation, and it should be more physiological. Like we know that the embryo normally in vivo, it just sits on the mucus. There is no culture media in vivo. But here we try to create all this with the culture medium, but we really don't know. But the conditioned media is going to be the future. Whatever is going to be seen in the in vivo system, that should be completely replicated in the culture system so that embryos can have better developmental potential. Another important factor we discuss a lot these days is the oxygen tension. We know that high oxygen tension is detrimental to embryos, because embryos normally grows in a hypoxic condition in the fallopian tube, where the oxygen concentration is around 8%, where in the uterus it is only 2%. So what is the point in keeping our culture in the embryos at 20%? You know that it is detrimental, but it is not a new concept. If you look at in 1960s, people used to grow the embryos with the animal embryos with the low oxygen culture with the kind of desiccator, but now we have more sophisticated machines. We have a modular incubator which can control the oxygen concentration, and studies so far have shown that low oxygen tension is beneficial with respect to pregnancy rate, with respect to implantation rate, and with respect to live birth rate, so it can be easily implemented in IVF lab. When it comes to embryo assessment and selection, the morphology based assessment is the gold standard, but we also have time-lapse technology, we have non-invasive PGT, and we have AI also in picture. So all this can be combined significantly, and so that we can integrate all this technology together, so that we can come out with the way to select the competent embryos to give us pregnancy. We have also worked on this machine learning process. We have also combined the metabolomic and machine learning process. The metabolomic approach, what we have used was we cultured the embryos and used spent media, because what happens, the metabolomic approach is that whatever is happening in the embryo, that is reflected in the spent medium. That is the idea of metabolomic. The non-invasive selection is the spent media analysis, and we identified the metabolites and then combined with the embryo morphology, and then use AI technology to see whether that can help in selecting the competent embryos. And this approach has helped us in selecting. We found about 80% sensitivity when combining machine learning with the metabolomic and morphology based analysis in predicting the competency. So now the technology is also being used to select the genetically healthy, or I can say the euploid embryos. There's a study which compared between the embryologist and AI in identifying the euploid embryo. It has been shown that the AI is more sensitive compared to the embryologist in selecting the euploid embryos. That means there is always a fear that embryologist may not be required in future IVF lab, or what is going to be the embryo lab is going to be simple, or it's going to be a complex lab. It's a very difficult question. But what is important is that without embryologist, lab cannot function. He or she should be there in the embryology lab, but the embryologist should integrate himself or herself with the technology and innovation. Then he or she will have the place. Otherwise, they cannot be in the IVF lab. So the modern embryologist is not only the technical expert doing ICSI. He or she should be a manager, good researcher, collaborator, scholar, communicator, and mentor. With all these qualities, he or she can be a successful embryologist. And one of the examples I can give here is the cryopreservation. If you look at way back in the 80s, we were using slow freezing with a big machine, and then we used to document all this here on a paper, the manual, the documentation. And then came all this manual vitrification. Parallelly, we also started with the barcoding and inventories. And now we have the faster way of vitrification, cryopreservation. And parallelly, we also document with the RFID technology and automation. In future, it's going to be both the process and management will be completely automated. And here comes the importance of the embryologist. He should be able to effectively integrate along with his knowledge and expertise. So then it's going to be the future embryology lab. The future embryology lab definitely will have more of automation. The precision, as you have seen in the ICSI video, I am sure there will be many more gadgets going to come in embryology lab like that. It may be in ICSI, or maybe in biopsy, or maybe in cryopreservation. And more importantly, there will be personalization, because as of now, most of the protocols used in IVF lab are very generic. We don't use protocols similar to clinicians. Clinicians make the patient-specific protocol. Unfortunately, here, whatever has been given by the company, we follow, which is not good. Our protocol should be the gamete-specific, embryo-specific, and also patient-specific. With all this, I cannot say that we are going to increase the success, but definitely we can significantly reduce the time to pregnancy. So I'd like to thank you, and also these are our collaborators who have helped in our research, and I also thank our core team and also our clinical head, Professor Pratap Kumar, where I have worked with him for 30 years and who is a great supporter in all our activities. And thank you very much for your attention.
Thank you so much, sir, for that impactful keynote address. We would now like to present a token of love and appreciation to Dr. Satish Adiga. May I kindly invite Dr. Sheila Balakrishnan to come forward and have